Welcome everyone today. My name is Joanie Bouchard. I am the Health Profession and Occupation Act lead for the college, so supporting our work to prepare the transition. And I'm also the Chief Regulatory Officer interim for the college. We are hosting this webinar today from our Vancouver office, which is located on the unceded and ancestral lands of the Coast Salish people, who are represented today by the Musqueam, Squamish, and Tsleil-Waututh Nation. So today, this is our seventh webinar that we have been doing to share information with all of you on our work and readiness to start regulating under this new act. Today, our topic is the Harmonized Ethic and Practice Standard, and Susan Paul will be leading the talk today. Susan is a regulatory transformation advisor for the college, and her focus is on quality assurance. She has been leading the project of developing our harmonized ethic and practice standards. She has gained a very deep knowledge of all of the legacy standards as a way of developing these. And so she will definitely have the best knowledge to present to you today. And Susan is also a physical therapist, so she is a licensee of the college. So I think with that short introduction, I will pass it over to you, Susan. And yes.
Okay, thank you, Joanie, and welcome to everybody today. So just to give you an idea of what we'll talk about, and we've got lots of time, so there will be lots of time for questions at the end. Thought I'd start by telling you a little bit about why we harmonize the ethics and practice standards, tell you a little bit about the development process, and then we'll talk about the extent of changes to the standards, tell you a little bit more about the content, and then I thought I'd address some of the frequently asked questions that we've heard either through some of the survey feedback or just from email from registrants. We'll wrap it up and then have, as I say, quite a bit of time for questions. So the first thing I'm quite keen to know is who's in the room. So I'm just wondering by profession who's here today. So I think Michelle is going to launch a poll for people. And if you can just click and submit, that would be great. We'll leave it open for a minute while people have a chance to complete the poll. Michelle, I can't see the numbers coming in, but it's probably reasonable time to share the poll. Okay, we might need to scroll down a little. Oh, I can, okay, got it. Okay, so mostly psychologists, and then a sort of handful from the other professions, just missing hearing instrument practitioners today. Okay, thank you. It's good to know. Okay, so probably the question on people's mind to start off is why harmonize? So let's talk a little bit about the current state. So at the moment, the college regulates 9 professions, but we do that right now with 7 sets of legacy standards. And while these standards are substantively similar, they do have inconsistencies across the professions. And so that can be problematic. The other issue is that there are gaps in current legacy standards with what's required by the Health Professions and Occupations Act. And so in order to be compliant with the HPOA on April 1st, we needed to update standards to ensure that the standards were compliant. It also aligns with some of the content of our strategic plan, which some of you may have seen. It was posted publicly on our website recently. One of the lines is to strengthen public protection through a unified regulatory approach that promotes consistency across professions while honoring profession-specific distinctions. And perhaps even more importantly, it aligns with what we hear from the public. So we have been hearing from the public for some time that they would like to see harmonized requirements, particularly around things like consent, privacy, records, communication. When they have a concern, and sometimes it involves multiple professionals, it is problematic for the public when they have to look to different standards to find differing requirements or similar requirements, but worded in different ways. So that is something we've heard over and over from the public, that they are interested in having harmonized standards. What do we hope the harmonized standards will do? Well, first of all, they'll ensure alignment with the HPOA. I'll talk about that a little bit more later. And they'll establish a consistent minimum expectation across all professions. And so that means that there'll be consistency in how licensees are treated in regulatory interactions. And it will, as I mentioned, it will help the public know what to expect. And importantly, the new standards reflect right touch regulation. And what that means is to ensure the right level of oversight, and that oversight is proportionate to the risk and it avoids over-regulation. It will also facilitate the scheduled review and updates as we move forward with the standards. So how did we develop them? Started actually just over a year ago. And for the initial stage, or part one, we engaged an external consultant to support the harmonization of the 7 legacy standards. And so that started out by us doing an inventory of all the legacy standards, codes of conduct, codes of ethics, and bylaws or bylaw schedules that had professional responsibilities within them. We did an environmental scan from BC and across other health regulators, including those who are multi-profession regulators, some internationally. We identified commonalities and differences in expectations in the legacy standards, and then we consolidated the standards, including the codes of conduct and codes of ethics where professions had those. And then we developed sort of a concordance or concordance tables with legacy standards to sort of map where legacy content was appearing in the new harmonized standards. And then we started the next part of the work, which was resolving the differences. So once we had that legacy content together, in consultation with practice advisors from the college, regulatory leaders, professional practice and standards advisory committee members, and our strategy, governance, and social accountability team within the college. So there was lots of consultation internally. Then the standards went out for legal review. And so that was more consultation and feedback to integrate. And then we went to external consultations. So we met with our quality assurance consultants, with the BCHR Indigenous Engagement Group, and the BC Public Advisory Network. And then many of you will remember receiving many emails and reminders about the licensee survey that happened from mid-November to mid-December. And we had 1,393 detailed responses. We had representation from all demographics and professions. And overall, there was 92 to 97% support for each standard. We also had some groups in health authorities or groups of practitioners that provided us with feedback by letter, which was actually really helpful, very specific commentary in the letters. And so we used all of that feedback. The next stage, part 3, was what do we do with all this feedback? Well, while I did tell you there was strong support for the standards in general, that strong general approval did not hold respondents back from making suggestions for improvement. And we collected thousands of discrete pieces of advice. And all of this feedback led to substantial revisions. So some of the revisions you suggested, you'll see those were directly incorporated into the standards, or in some cases, issues that were raised were addressed where possible. We also worked towards simpler language, greater clarity, and more accommodation for different practice settings. So one of the things that came up quite a bit was the difference between sort of working in a public setting versus a private setting, and who was responsible for what parts of some of the things in the standards. And so we've tried to, in some, you'll notice in some sections of some standards, there's language to account for different sort of practice settings. But what I really want you to know is that we made hundreds of changes with all these improvements in mind. So the extent of the changes, how are they different and how are they the same? In general, most of the requirements reflect existing expectations and will not significantly change how licensees practice. And that's because the legacy standards were the basis of these harmonized standards. So that's why it shouldn't be, what you're seeing in the harmonized standards shouldn't be a big departure from the expectations of legacy standards. So the legacy standards and guidelines and other materials will continue to be a resource at a more detailed level for each profession. So if you go onto the college website under for licensees, you'll see practice resources as a dropdown, and all of the legacy guidelines supporting resources are listed, or I shouldn't say all of them. Many of them are listed there. And in addition, the legacy standards on a separate page, which I will show you, the legacy standards will remain. And so where there's quite a bit more sort of prescriptive or drilled down detail around practice details specific to your profession, you can continue to look there for more detailed information. And the one thing to keep in mind is where the requirements are different in the legacy standards compared to the new ethics and practice standards, the new ethics and practice standards prevail. So we'll talk about what some of those things are. For example, the retention period that has changed and so on. Some legacy standard content included things like licensure responsibilities or licensure requirements, and that content is not in the harmonized ethics and practice standards. Rather, that appears in bylaw. So, talked about earlier the HPOA requirements and the need to make sure that the standards are aligned with those HPOA requirements. So, we need to ensure that the standards are aligned with the HPOA guiding principles that are set out in Section 14 of the Act and the anti-discrimination measures that are required in Section 15 of the Act. The Act requires or has some mandatory reporting requirements that are a little bit different than the duty to report requirements that appear in the HPA currently. So the sexual misconduct and abuse duty to report has been made a little bit broader, and now there's a duty to report discrimination that didn't exist under the HPA. Some colleges didn't have standards on things like restricting sexual relationships with patients or treating family members, and some of these details are required in the HPOA. So in Section 70 and 72, the Act actually sets out that we need standards to address certain things, and so not all of the standards from legacy colleges contain all of those details. There were some gaps. Additionally, there's now explicit use of title provisions in the HPOA regulation. In particular, that's around the use of title doctor. So if you are a profession that is authorized to use the title doctor, there's some quite specific HPOA regulation wording around that, and that's now reflected in the ethics and practice standards. Delegation is a word that has previously been used to mean a lot of different things by different colleges. Delegation is now defined in the HPOA, and the way that that's defined in the HPOA, it also anything that is being delegated must be authorized in bylaw. And so if you haven't heard the delegation webinar, I would encourage you to go to the college website and listen to that recording if you are one of the 4 colleges that does delegate. So that's audiologists, hearing instrument practitioners, SLPs, and optometrists. So as mentioned earlier, that we wanted to align the inconsistencies. So these aren't all of the examples from the 7 sets of legacy colleges. They're just some of the examples. So it is important that people do go and read the standards right from beginning to end to make sure they catch any of those details that change for their profession. Some of the biggest things that we've either heard about or that we wanted to flag for people, things like the record retention period. So for several professions, that's an increase to 16 years under the harmonized ethics and practice standards. So several of the colleges, OTs, PTs, we already had a 16-year retention period, but many had a shorter retention period. And that we're gonna talk specifically about the rationale for that in a couple of slides. There's now a requirement to document consent, and not every profession in legacy standards had that requirement. Co-signing for student entries is no longer a requirement in the standards, rather it's an option. And there are some changes for expectations in maintaining records after somebody ceases to practice. So there's a requirement for a succession plan in the event of unforeseen circumstances, what would happen to the records. Psychologists are no longer required to have an executor, but that still remains an option. So if that's something that's working well for you, you can certainly carry on with having an executor. But there are more options now, including former licensees. So, for example, if you were a psychologist, you couldn't be a former licensee and still retain records. And now the standards allow for a former licensee to retain their records. And importantly, if the records are relocated when you stop practicing, then there's a requirement to notify the college of their new location within 30 business days. And mostly that's because we want to facilitate, if somebody needs access to their record, we want to help them find it. The level of detail. I think this is worthy to note. Some professions included a lot of detail in the requirements of their standards, and others provided quite high level requirements. So it depends what profession you are from, whether the detail level in the harmonized standards is a departure from what you're used to or not. And I understand that feels different to see a higher level of language, a less prescriptive level of language in the standards. And that reduced detail was intentional. So that's intended to align with right touch regulation principles and really to allow for professional judgment. So with a higher level of language in the standards, it does allow a health professional to use their professional judgment based on the patient in front of them, the context of practice, to make decisions that will still meet that line of the standard. So we want you to know that that legacy profession specific content that aligns with standards, the harmonized standards, will be repurposed into guidance documents. So we know that many professionals find that really helpful. And so we don't want that to disappear. And where it aligns with the standards, we will be pulling that out and turning those into resources or guidance documents for licensees. Marketing, advertising, and promotion. So one of the big changes here is that some legacy standards prohibited testimonial use, and it is permitted under the harmonized standards. It's been included in the marketing, advertising, and promotion standards. So what that means is all of the requirements in that standard apply, whether you're using social media, whether it's a website, whether you're talking about testimonials. So things like it must be verifiable, can't create unreasonable expectations or guarantees about results. If you read the marketing, advertising, and promotion standard, everything that's required there also applies if somebody is using testimonials. And use of someone's role as a licensee for marketing unrelated to their scope of practice. So that was prohibited in some legacy standards, and it's now been extended, that prohibition, to all licensees. So that prohibition of using your role as a licensee for marketing that isn't related to scope of practice. The Indigenous Cultural Safety, Cultural Humility, and Anti-Racism Standard. So that won't be a surprise to anyone. That is the one standard that we were all aligned on, in fact, when we amalgamated. So the existing Indigenous Cultural Safety, Cultural Humility, and Anti-Racism Standard remains unchanged because we don't want to get out of alignment with the other colleges that also use this standard. And the HPOA guiding principles and anti-discrimination measures, you'll find those sort of reflected throughout the standard. So those were really at the forefront of our thinking as we were harmonizing to ensure that we were including the requirements of the HPOA on those topics. Tell you a little bit more about the content. So if you haven't seen them, they are posted on the website, but there's the Code of Ethics at the is part one of the Ethics and Practice Standards, and part two are the practice standards with the 15 titles listed on this slide. So everybody got an email with the link to the standards, but if you are looking for them on our website, if you go to the homepage, you'll see the header for legislation, bylaws, and standards, and then you'll see the drop down. And on the drop down at the bottom, you'll see ethics and practice standards, and that will bring you to the page with the purple button that you see on the slide that will open the PDF. We are hoping when we move to a new website that we will be able to display them differently, perhaps as singles or on web pages as opposed to one long PDF document, but at the moment that's how they appear. So how should you use them together, obviously? So I always think of the Code of Ethics. In my head, I kind of think of it as a bit of an umbrella sitting over top of the standards, and it outlines an ethical framework for professional conduct and decision-making. And I often look to the Code of Conduct, the Code of Ethics to guide decision-making if I can't find something either in the HPOA or the regs or our bylaws or our practice standards. If the regs and et cetera are silent on a matter, sometimes I can find an answer for what I'm looking for or help, my thinking or my ethical decision making by going to the code of ethics. And then the practice standards set the expected minimum achievable level of performance and conduct, and they're designed to provide clear, actionable expectations. So those are really the requirements that are all articulated in the practice standards. So we've heard from licensees, we've heard some questions and concerns, so I thought I would raise those now before we get to the question period. So we did have some feedback that not all of the requirements apply to my practice, and I think that would actually be the same largely for legacy standards. So certain standards address circumstances that don't arise in every profession or in every practice context, and that's okay. There remain a few profession-specific requirements within the standards. So there are a few occasions where you'll see something that's addressed specifically to one or two of the professions. Why the term patient? So we heard this a lot. It's not the term we started out with, and it was raised across all of our consultations, not just licensees. Ultimately, we did go with the term patient because it aligns with the language in the Health Professions and Occupations Act, and we are trying to remain consistent with the Act. And importantly, that was what legal advice supported, was use of the term patient. So we are aware that patient isn't appropriate for all practices of all licensees or in all practice settings. And so you'll see that we've made some revisions in different places in the standards to attempt to clarify the nature of the relationship. So you'll see patient, sometimes you'll see individual being assessed. So we are aware that is the term we landed on, but in addition to patient, you'll see individual being assessed. Retention period, 16 years. So we have had several questions from licensees who had legacy standards that had shorter retention periods. And we do recognize that's an increased burden for some professions. It aligns with the legal advice again, and that legal advice is really connected to the BC limitation periods that are outlined in the BC Limitations Act, which means that a civil suit could be filed. Potentially, the ultimate limitation act could be up to 16 years. And so it's better for patients and professionals if a civil suit were filed to have a clinical record or a record available. And it does align with other health professions in BC. So we had some questions about that. So it aligns with the physician requirement, the oral health college requirement, the BCCNM, so the nursing and midwives requirement. So it does align us. And as I say, several of the legacy colleges already had a 16-year retention period. And just to note that applies, that new retention period applies as of April 1. So it doesn't apply to records that have already exhausted the legacy retention period prior to April 1. But if you have records that are sort of midstream in that retention period, then that retention period just got extended, or it's not April 1 yet. So that retention period as of April 1 is extended to 16 years. So we intend to put something in the next newsletter to clarify that a little bit more for people who have questions about records that are sort of transitioning. Profession-specific expectations. So we really do want people to know that the ethics and practice standards are not intended to reduce the expectations of any of the professions. So that sort of less prescriptive language does not or should not equate to a change in the way people practice. It's not intended to reduce expectations. And that profession-specific guidance, as I say, can continue to be found in legacy documents that are still available, in particular the legacy standards. And those how-to details that are in legacy materials, they will be incorporated into guidelines in the future. And just you might be interested to know, across the professions, we have over 300 resource documents. So it takes some time now to review those documents, ensure that they are in line with HPOA requirements and with the requirements of our new bylaws and standards. So our practice advisors and staff were working to get those resources or guidance documents reviewed and reposted as soon as possible. And I also want to remind people that if people are concerned, if there is a complaint or an investigation, the college panels actually include and must include members of the licensee's own profession, and they will be in a really good position to be able to apply the standards to that profession-specific context. So, for example, if there were a complaint about an optometrist, the investigation panel will include several optometrists who will then understand how to apply the ethics and practice standards to the context of optometric practice. I do just want to take a moment to acknowledge, it is a big shift to go to harmonized content. And I think, and some of you might be feeling that it can feel like a loss of identity for some to see that shift to harmonized content. Again, not intended to change the practice of the profession significantly unless there are things that didn't align with the HPOA requirements or where we aligned inconsistencies that didn't make sense. So you can imagine that registrants or licensees talking to each other found that awkward that, the OT had a different retention requirement than the dietitian on their same team, or across the professions that the retention period was different. So some of those things were important to align. And as I say, I've mentioned a few at a high level of the changes in the standards, but it is important to read all of the standards, and I'd say including the introduction for context, to make sure that you can see, are there any other little pieces that you'll want to adjust to make sure that you're aligned with the standard requirements. And we've had a conversation that we will likely plan some additional webinars, perhaps in more profession-specific groups, to talk more about sort of the changes that are profession-specific and how those have mapped into the harmonized standards. We expect you'll have questions. And so a really great resource, we have practice advisors. So we actually have profession-specific practice advisors for every profession. We're actually hiring, in the process, we have a posting for a school psychologist practice advisor. So if you have questions, please do reach out to practice support at chcpbc.org for a conversation with a practice advisor. And just want to recognize that we are all navigating a new framework under the HPOA. So a new act, new bylaws, new standards. For several professions, we will newly have restricted activities and certified practices. Some professions will have new certified practices. So there will be a learning curve for everyone, including staff. And so I think in the short term, you might expect that responses will take a bit longer as even staff get comfortable with all of the new framework, the new documents, the new act, the new bylaws, the new standards. So we still have one more HPOA webinar coming up on March 23rd at 4 o'clock, and that's on restricted activities and certified practice. And you can register for that on the college website. And again, if you are interested in hearing any of the previous HPOA webinars, they've all been recorded and posted on the website. So we have governance and bylaws. We have one on licensure, delegation, the legal framework for human rights obligations under the HPOA and understanding anti-Indigenous discrimination, and public protection, complaints, discipline, and support programs. So those are all recorded, and you can sign up to, or you can head to the website if you want to hear those recordings. Just in summary, the harmonized ethics and practice standards establish consistent minimum expectations across all of our licensees. They address the legislative gaps for the HPOA, and they support modern right touch regulation. And the board approval of the standards, the approval is still pending, will allow the repeal of the 7 legacy standards and codes and implementation of the harmonized standards effective April 1, 2026. I apologize. I realize I probably spoke quite quickly there. So if anybody needs any of the slides, me to revert to any slides or has questions, I think Michelle is going to moderate the questions, and I think Joanie has probably been answering some in the background.
Yes, absolutely, Susan. Thank you. We've got a number of questions that have been submitted in advance, so perhaps we can start with those. There's one here about the use of testimonials, and I know you touched on that in your slides, but perhaps you could just reiterate, what is the recommendation regarding the use of testimonials by health professionals starting April 1? Some professions were discouraged from using them in previous versions of their profession-specific standards.
Right. Yes. Yes. There was a lot of conversation, and it actually shifted even as we were building the standards. We do know that some professions, some colleges in other provinces, even who prohibited them, it becomes very difficult in 2026 to police that. So it became unsustainable, and some of the colleges had to kind of walk that back because they are kind of ubiquitous. So when we really thought about what is the risk of harm to the public, it's around, guaranteeing results, or I want to pull up the marketing standard, because I feel like where we finally landed was the risk of harm is articulated well in our marketing, advertising, and promotion standard around what any marketing has to meet, or what the requirements are. And so at the end of the day, we decided, well, let's apply that to testimonials. So, you know, the standard says things like they have to be factual, accurate, verifiable, can't be incomplete, misleading, deceptive claims, or claims that could reasonably be interpreted as misleading or deceptive to the public. So I think at the end of the day, we were comfortable with sort of saying that if someone is going to use testimonials, it must meet everything in the marketing, advertising, and promotion standard. But there was a lot of discussion, and I will say that from version to version, we even changed the wording as we thought about it more, received more feedback, you know, had those responses, 1,300 responses from registrants. All of that informed where that landed.
Thank you, Susan. I'm just going to jump to one of the questions we received live during the session, because it also relates to marketing, but I'm not exactly sure where it falls into the presentation. It was something that you spoke to with respect to use of role as a licensee related to marketing. Do you know where that might be getting at?
Yes. So yeah. So it was in some colleges, legacy standards, that you couldn't use your role as a licensee to sort of give weight or you know, like prestige of that profession to something that was unrelated to the profession. So something that's not related to your scope of practice. So that was prohibited, and it was in several college legacy standards, and that's now carried over into the ethics and practice standards.
Thanks, Susan. We did receive a question, actually a number of questions in advance about the 16-year retention, and I think you've addressed that. There is one in the live chat about the 16-year retention period and the age of majority or age of children, and I was wondering if you could speak to that.
Sure. Thanks, Michelle. Yes, that's an important caveat, so thank you for mentioning that. Is that, and the standard on records includes that, that the retention for minors records actually, so if it's a record pertaining to a minor, it's actually to the age of majority, which in British Columbia is 19 years of age plus 16 years. A long time.
Thank you. Okay, I'm sure there are a number of other questions about the 16 years in the chat. I'll get to some of the questions we've received in advance. There's one in here about, will retired profession-specific standards be maintained over the long term as references? If they will be retained, will the college resources available, will the college update those as needed in response to professional, social, and technological developments?
Yes, oh, sorry, what's the last part of that again?
Like, will they be updated if they're retired? Like, to respond to, I guess, the changes in regulation in healthcare.
Yes. Oh, yes. So I think there's a few parts to that. One, they have to be maintained because you can imagine if there was a complaint from 2 years ago, then the inquiry, I'm sorry, I always struggle over this because under HPOA, it will be investigation. The investigation committee will need to refer to the standards that were in place on the day, or, you know, at the time when the complaint, when the incident occurred. So inquiry will need them for a longer term, and then in the shorter term, they're going to remain so that we don't pull that more detailed information from registrants until we have those practice resources developed and updated. And so I think at some point, it's possible that they won't be sitting publicly on the website as they are now, once we have those resources available and we've taken the information, that detailed sort of profession-specific information, and updated our resources and guidance documents to reflect it. And then I think the last part of the question is, will they be updated? And absolutely. I mean, the standards will now, they'll probably on a, cycle, we will look at a couple of the standards every few years and work to update them. I think that was the extent of the question, Michelle.
Yeah, that's great. Thank you. And I was wondering if you could speak a little bit to like the level with which the standards are, and how profession-specific guidance or resources, you know, they may not rise to the level of that sort of harmonized level. I I know you've spoken to it in the past, and I was wondering if you could, speak to that a little bit for the group.
Sure. So some of the standards drilled right down into practice requirements, how you practice the profession. And some of them like sort of talk about, what you have to do as part of an assessment, or specifically what equipment you must have, or very specific details around how you practice the profession. But the reality is those things are best taught and examined by the educator. So those are things, some of those details are things that we learned in becoming the professional, and then, took licensing exams. And so things that are very profession specific, right down to sort of the clinical details of how you practice a profession. So that information is better suited in a guideline that will help somebody understand perhaps how they would meet the line of the standard that says you must have the appropriate equipment to conduct safe, ethical, assessment and treatment of your patients, rather than having a list in a standard. Part of the trouble with that is somebody was just mentioning in that last question about the evolution of technology and practice. And so if a new widget, machine, whatever in your practice becomes available and is now best practice, and it's not reflected in the list in the standard, now the standards are inaccurate. We have to update the standards. So in many regards, it's actually better to have the standard at a higher level that says you're required to have the appropriate equipment to conduct your practice safely and effectively, rather than that sort of prescriptive list. And that list might be helpful in more of a guidance document, but it also, the reason it sits well as a guidance is, if I am a practitioner in a pediatric setting versus, elderly clientele with a very, focused on a specific type of, presenting condition, the equipment that those two practitioners from the same profession should have to provide safe and effective care likely looks quite different. So the standard at a higher level allows for those differences that still mean that the practitioner is meeting the standard and providing best practice in sort of at the level of what the current practice guidelines would suggest. So I think it's just about getting the information in the right place. Does it belong at the level of the standard, or does it belong as a guidance document of here's how you might meet that standard requirement in your profession?
Thank you, Susan. We've got a question here about a specific standard. It says one of the standards indicate that we are authorized to use the title doctor. I know you spoke to that. Mm-hmm. We have to indicate that we are not a medical practitioner or not authorized to practice medicine. Could you please elaborate on what this looks like in practice? For example, can we still refer to ourselves as Dr. X psychologist?
Yes, so that's a really good question. And that's so that appeared in the regulation. So that's drafted by the ministry. I think it's section 5 of the regulation, Joanie, is that correct?
Yes.
Where it actually, thank you. It specifically says I'm going to paraphrase, but something along the lines of if you're authorized under the Act to use the title doctor, that you must make clear that you're not providing or you're not practicing medicine. And so what does that look like? I'm not sure we've really gotten there yet. It is something that we will likely develop a resource on, but I think that's a fair point, is if you say, Dr. So-and-so psychologist, that's, to my mind, is making it quite clear you're practicing psychology. So I think the question would be, if you looked at somebody's business card, their website, the materials they put out, any advertising or promotion, is it clear that they're practicing psychology, or would the public reasonably be able to believe that they might, or reasonably think that they are practicing medicine? So I think it's about making clear that you're practicing psychology. I think that's as I say, we don't, what exactly does it look like? Are there any more rules? We don't have that sort of in print yet, but I think it's really goes to sort of the general use of title concepts around making sure that we are not misleading or misrepresenting ourselves in the way that we use title. And so I would extend that to that piece around, if I'm entitled to use doctor, that I'm making it clear that I'm a doctor of optometry, or Dr. So-and-so psychologist, so that it is clear to the public what service is being provided in that interaction, and that they wouldn't reasonably be thinking that they were seeing a medical doctor.
Perfect. Thank you.
Joanie, did you want to add anything to that?
No, you covered it really well. We will most likely look at providing some kind of resource and guidance just to make sure people are feeling reassured that they're meeting the standard in terms of using the title appropriately. But the approach of ministry to add this in the regulation, which was not anywhere in any regulation before, it's been added to all college regulation, is kind of now providing the direction that we now have to make sure we interpret and work with. But the way you laid it out, I think, was very clear, and that's where we are at this point now.
Great. I've got another question here back to testimonials. Were any considerations given to the ethics of soliciting testimonials from patients, and is this accounted for in the standards?
Yeah, I mean, I think that's accounted across like everything, right from your code of ethics to conflict of interest to promotions and boundaries. So I think that, you know, people would need to reflect on whether that is putting an undue sort of burden on your patient if you are soliciting testimonials, whether that's really respecting sort of the client's interest. There's a whole bunch of pieces there that I think we could, you know, sort of like pull out of the various standards, as I say, code of ethics, conflict of interest, communication, and the marketing promotion advertising standard that would help people think about, you know, what are the risks, patient risks around actively soliciting testimonials from patients.
Thank you, Susan. I'm just going through the live questions here. When does our completed and updated informed consent forms with updates related to HPOA and new ethics need to be completed and now in use, I guess, for April 1?
Yes, so that might be that could be a question, say, from an optometrist who their standards didn't explicitly say they had to document. So they've always had to get consent, but they didn't explicitly say they had to reflect that in the clinical record. So yes, that will be in effect for April 1.
Great, thank you. I have a question here. It is specific to psychology. Can you expand on psychologists not needing executors? What is the expectation if a psychologist who is actively practicing dies, and what is expected?
So that's laid out in the record standard. So it doesn't change the requirement to have a succession plan. It just gives a few more options beyond naming a sort of a formal executor that you have to report to the college and so on. So I would say that the expectations don't change. The expectations are that you comply with the retention period, that the records will retain secure and accessible if a patient needed to access them during the retention period.
Thanks, Susan.
And you can still keep an executor. Like if you have somebody who's agreed to be an executor and manage records for you, you can carry on. So it just means that there are some additional options if you wanted to, again, if you retire and you want to hold your own records, then you can do that. Under the previous standards, the code of conduct for psychologists, that wouldn't have been permitted.
Great, thank you. I've got a question here. Lisa and Joanie, it may also speak to some of the work that you're doing. It is a bit sort of adjacent to the standards work, but I think there is some overlap. Can you comment on any changes to informed consent, specifically as it relates to confidentiality, that might be necessary as a result of the implementation of the HPOA? As it stands, it looks as though clinicians may be compelled to release records to unlicensed members of the public without client consent, such as during the random quality assurance assessment. This creates a conflict between the ethical obligation to maintain confidentiality and the requirement to cooperate with the college.
Yes, I can take that one. We actually have addressed this question and topic quite in detail at the webinar on quality assurance program and continuing professional development. Just to very quickly, but I would encourage people to go watch it. I want to make sure we have time for other questions, but want to also take the opportunity to clarify. So the authority for the college to access records under the HPOA is not a new power. This already exists in the Health Profession and Occupation Act. If you look at the Code of Ethics, for psychology, this was already included that the college could access records for the purpose of quality assurance. Under HPOA, the way we are building the new quality assurance program, there may be a component of the program that includes audit of records. This was explained at the webinar as to how this will work. It will not be all licensee that will go through the quality assurance assessment, and there will be a multiple step approach. So it would not mean that if you're audited that we will actually request access to your record. We would also probably ask for different type of records. We would not say that we want a record. This is not done in the context of a complaint. And so the health professional would have the liberty of choosing what records are relevant for the college to audit. And as we explained in January, there would also be the possibility of raising concern with access to a specific file and discussing with the quality assessor, which would actually be from the same profession, which is a requirement under the Act. So only psychologists would audit the record of psychologists in the context of a quality assurance assessment. So I don't want to maybe go on too long on that question, but we have provided lots of information. I know it's an ongoing concern, but this is not a new authority that the Act is providing, and it is our position that this does not require a change in your consent form, because the likelihood of the college actually requesting access to your record after all of these elements that we've mentioned is actually pretty low, and there's more risk of breaching trust and limiting people to engage to get access to care. So potentially more negative consequence about that. So I think I'll keep it at that, but we're happy to provide more information about this.
I just wanted to add one thing, because I've just pulled up the current code of conduct for psychology, and it's actually if the registrant who had the question, if they want to have a look, it currently exists in your current code of conduct. So it's section 616. Provision of records to the college. A registrant is not in breach of their confidentiality obligation to the clients if the registrant provides their clinical records or other documents related to their practice to authorized persons in response to a request from the college in the course of an investigation of a complaint, a registration matter, or a quality assurance matter. So just to let people know, that's absolutely not a new thing, that's actually in the Psychology Legacy Code currently.
Excellent. Thank you both for addressing that. I know that we have had a number of questions and concerns around that one, so it's really good to get that on the record here in this webinar as well. It looks like, Susan, there's some confusion around the retention of records and how that connects or does not connect with liability insurance requirements, which I know is a bit of a licensure piece. And I was wondering if you might be able to speak to that. Does the 16-year change in retention for some professions, does that equate to lengthening of a requirement for liability insurance?
Okay, so I wonder if that person means, like, does the college require people maintain liability insurance after they cease practicing? Because as long as you're practicing, you'll have liability insurance. Currently, the college bylaws, and Joanie can correct me if I'm wrong, but there's no bylaw that requires liability insurance to extend beyond the point at which you're registered. But I feel like we could have a whole webinar on this, because health professions liability insurance tends to be claims based as opposed to incident based. So it matters if someone has coverage when the complaint is made. And so many professionals, when they retire, they talk to their insurer about something called, they sometimes call it tail end, or I'm not sure what they officially call it, but some insurance to follow you into your retirement when you're no longer a registrant, to protect in those events. But I'm not the best person to ask about the details of that, but that is something that health professionals often look to in retirement, is to extend their liability coverage, but that's not specifically connected to the 16-year retention piece, no.
Yeah, maybe what I could add is that the fact that the records needs to be kept longer, that doesn't change the uh, whether it was 7 or 2 or 16 years. People can come to us and make a complaint whenever they want. I think the fact that the records can be accessed longer is actually a way for people to be able to show if they've met standard. In terms of the coverage that you are required to hold, the coverage, the requirement in bylaw is tied to when you are a licensee. If you want to know if that changes your liability to have a longer record keeping requirement, that's something that can be discussed with an insurance broker, depending on the plan that you have, whether it's per claim or per occurrence, if you have an aggregate amount, and what Susan alluded in terms of detail. And it becomes very individualized with your plan, and also probably your own personal risk tolerance. But we would encourage people to discuss that with their insurance broker. The requirement from the college is tied to when you are a licensee.
And from a liability perspective, we know that like weight is given to what is recorded in a clinical record. And so as Joanie is pointing out, if there were a complaint made, at the 10-year mark, it is, I sort of mentioned earlier, like that's to the benefit of the patient and to the health professional to have that record, that account of what occurred. And it is given weight if something is documented in a clinical record.
Thank you both. Yeah, we're seeing a lot of more comments in the Q&A about space requirements for 16 years, and there's concerns around the 16 years, but I know that there was sort of an exhaustive process with legal and other health regulators to determine that year. So it's interesting. We are seeing some folks that are asking questions about the 16 years. Switching gears a little bit, it's specific to psychologists, but I'm wondering if you can comment for all the professions we regulate. Are health professionals still required to list their registration number after their name?
So I might go to Joanie in this. I believe the answer is no, and partly some professionals actually. I think it depends on what context you're in. So it's different on a receipt versus everywhere. And part of that, I know for the Legacy Physio College, there were concerns around like access, if everyone has access to your billing number, your licensee number, there can be connection to fraud. So it's not always appropriate to, or people may not always want their license number next to their name for a variety of reasons. So Joanie, you can speak to that, but the standards don't require a licensee to have their registration number or their licensee number next to their name.
Yeah, sorry, I missed the last part of the question because I was just going through the question in the chat and see if I could answer some as you were answering that one. So I split my attention for 2 seconds.
Yeah, so the psychologists in particular in their code of conduct have in their legacy standard or the legacy code of conduct have a requirement that they list their license number next to their name, and wondering if that's a requirement going forward. And I was saying that the standards don't require it, and I don't believe the bylaws do. And sometimes there's a consideration around protecting that number a little bit from we have had cases where it does get used fraudulently. So there is some sensitivity around that number sort of just being
posted. It is not a requirement. I know that there might be a requirement for some insurance. So for patients actually getting coverage. But from people to be able to verify that you are licensed on the website, the licensing number is not required. People can search by name, and therefore it is not a requirement in terms of being a way to identify if someone is a licensee of the college. And so if people want to continue this practice because it is useful for a bunch of reasons, they are welcome to do that. It is just not a requirement from the college. And I think as Susan presented earlier, I think when we try to make decision and harmonize, we really try taking an approach as if, is it us who needs to require that, or is that requirement belonging to someone else? And in that case, again, for us in terms of public protection, like we want to make sure that people know your license, and there's a way to do that with your name and not necessarily with the licensee number. And so we decided we didn't need to add an additional requirement. Again, doesn't mean that you guys cannot continue to do that if that is useful for other purposes.
Yes. And again, continued good practice to have on a patient-specific receipt, obviously, because as Joanie said, for insurance purposes, that's often required. But the psychology code of conduct had a much broader requirement around pretty much any time your name was listed, I believe. I'd have to go back and double check that. But I think that's probably what that person was asking about. So I don't think, people are contemplating taking it off their receipt to the client. But in terms of having it everywhere, that's not a requirement of the standards.
Further to that and what needs to be displayed for the public and clients, patients, there is a question here about change in title from registrant to licensee, and
Yes.
if professions will need to change a designation from registered to licensed, what the requirements might be. I know we've addressed this in another webinar as well.
Yeah, I'm happy to because it is confusing. So I mean, technically on April 1, we go from being, based on the way the Health Professions Act was written, to the Health Professions and Occupations Act, we go from being registrants to being licensees. But the reality is all of our titles are protected. So when I say Susan Paul, physical therapist, the implication is that I'm a licensee or registered. Otherwise, I'm not allowed to use title. So in fact, it's important that I say Susan Paul, physical therapist, but I don't have to use either. There's no standard that requires me to say licensed or registered, because by the very fact that I'm using title means I'm registered. So if people prefer to continue to say a licensed dietitian license, that's obviously permitted. It's not required. And I also think, we talked about earlier this sort of, there's going to be some transition from, into this new framework. I think that when you think of risk to the public, if your letterhead or existing cards currently say registered psychologist, and you're going to wait until you do your next order, you're going to wait until you update your website with some other changes. And so it's going to, on April 1st, if it still says registered, I mean, the implication is the same, right? Is that you're registered or licensed with your college. But it's not a requirement, because by the virtue of the fact that you're using title, you're registered. And technically, if you want to be accurate with the language of the act of the day, it would be licensed as opposed to registered, but there's not a requirement to put that in front of your title. Joanie, do you want to add?
Yeah, just very quickly, that neither of these terms have ever been protected. So I know some colleges have taken the approach of either requiring, or just culturally over the years, people have just been using this way of presenting themselves. But anybody under HPA was able to use the term registered. I'm sure you are seeing it out there in the spectrum of people who are unregulated. And that will be the same under HPOA with the term license. It is not protected. So technically anyone can call themselves a licensed something. And so that's why I think for us, we are trying to approach this as to your title is the way of showing that you are actually a regulated health professional, and if you use it, that means you have an active license with us. And so, as Susan explained, like it's not that like we're saying you cannot use it. It's more rather clarifying that the use of that doesn't add anything, or is also not protected. Anyone else out there can use that. So.
I'm just mindful of time. We have a lot of questions that look like they've been responded to already, but we will go through them and make sure that the website does reflect answers to all of the questions we're receiving. So a lot about the retention of records, the new 16 years, a lot around consent in the QA program. So some items that have been asked that are kind of adjacent to the topic that we're talking about today. So I might suggest we wrap things up.
Yes, that was my cue. Thank you. I was, again, trying to type a last answer in there. I know there's been lots of great engagement, which we really appreciate. And we are trying to offer more of these webinars with the hope that we're able to answer a question on a more regular basis. There are other ways to connect with us. Obviously, you can reach out to Practice Advisor at the college. We have We have one for every profession, soon to be. We are currently advertising to recruit a school psychologist as a practice advisor. You can go on our website, which has a lot of information, and you can also connect with us just through our general email address. As Susan mentioned, we have another webinar next week. We will be on restricted activity and certified practice. And we also have been discussing how we think it would be of value to be able to host additional webinar where we might be able to go a bit deeper into some of the changes in the standard so that we're able maybe to address some of these remaining area of concern or interest with all of you. So stay tuned. We will probably communicate that in a future newsletter. So thanks everyone for engaging and attending the webinar, and we will see you at the next one. Thank you.
Thank you.